CDH is a birth defect that occurs about in 1 in 2,000 pregnancies, whereas a defect in the diaphragm, either the left or the right, that leads to intrathoracic herniation of abdominal contents. When this is suspected, we work with our referring providers to either number one, confirm the diagnosis, and then provide a way to assess the severity and help guide the management as much as is required. We receive referrals where there's the question of diagnosis, the question of what the best care path is, the intention for a second opinion to counsel patients more completely in a care setting where you just have seen more pregnancies with CDH. And so we work with our providers to get the patients in and then meet the initial needs. And then the next step really is, where do the parents stand in terms of the information that they desire to make further decisions and what are their needs. And then we coordinate with referring providers what can be done at the center, what can be done through co-management, and what's the best path for the pregnancy. I think the most important ultrasound finding that's telling that there might be a diaphragmatic hernia is a mediastinal shift, so that the heart is displaced either to the left or the right. That should prompt a referral for diaphragmatic hernia evaluation. And the reason why a referral is also important, because some of the other abnormalities that might be present, particularly in the heart, are actually quite difficult to diagnose when you have the presence of a diaphragmatic hernia. As a community provider, if you suspect a CDH, the benefit of an urgent referral to a fetal therapy center is that you can evaluate the best option for the management of the pregnancy moving forward, and that the pregnancy and the baby has the opportunity to be delivered in the care setting that provides the baby a best chance. A diagnostic workup for CDH includes a high-resolution ultrasound, a fetal echocardiogram, MRI imaging, consideration for genetic testing, and also assessment of the mother for any obstetric risks that might be associated with preterm delivery or special delivery considerations. So the severity of a congenital diaphragmatic hernia is assessed by looking at the side of the hernia, looking at the lung size, looking at cardiac anatomy and looking for associated cardiac defects, looking for any markers of genetic abnormalities, and performing invasive testing if required and requested by the patients. As far as the prognostic parameters, we have now moved to using the observed to expected lung ratio, which is a fixed percentage across gestational age and actually provides the most accurate and reliable predictor of pulmonary hypoplasia, which is sort of the key factor that plays into immediate CDH survival after delivery. In addition to that, we look on the MRI at lung volumes, mediastinal shift, and we look at also the herniation of the organs. So liver herniation is an independent risk factor. Liver herniation is usually ubiquitous if you have a right-sided hernia. So with all these parameters in place, we will then say, like, what is the lung size, what is herniated into the chest, what are the associated abnormalities, and that typically grades the hernia severity into mild, moderate, and severe. The criteria for fetal interventions for diaphragmatic hernia have recently changed. We can now offer fetal for left and right-sided diaphragmatic hernias. For left-sided hernias, it needs to be an isolated hernia without any additional genetic or physical abnormalities, with an observed to expected lung-to-head ratio less than 30%. For right-sided hernia, the same criteria apply as well, with the difference is that the observed to expected lung-to-head ratio is less than 45%. And both of these hernia categories, left and right, are eligible for fetoscopic tracheal occlusion that has to be performed before 30 weeks. So we have almost a decade experience now offering fetal therapy for CAH. Our experiences have been that the survival is far over what you would expect from the published literature. So our average survival until discharge and beyond that is 82%, which is significantly higher than what is reported in the randomized trials. As a fetal therapy center with a special focus also on looking at obstetric complaints of the mother, we have been very successful in achieving a delivery gestational age at term. So our average gestation age at delivery is 39 weeks, which is quite in contrast to 34 weeks, which is observed in most of the publications. This term delivery has several advantages. Number one, it keeps all the management options open for the infant, and it also gives the lung the additional advantage to mature beyond the time of balloon removal. So that's been our experience at the center. The benefits of fetal intervention is that you minimize the risk and severity of pulmonary hypoplasia at the time of delivery. And that is the single biggest gatekeeper of survival. The risks are related to doing 1 or 2 fetoscopies, and those risks primarily are preterm labor, preterm rupture of delivery. And for a baby with diaphragmatic hernia, it's a significant risk because unlike other babies, a hypoplastic lung can not really handle a preterm delivery on top of that very well. So those are the biggest risks. We will communicate all of these risks very clearly with our parents, and we will also include our pediatric colleagues that have taken care of all of our hernia babies over the last 10 years to discuss what measures we put in place to try to mitigate these risks and what our positive and negative experiences have been. For parents that decide to deliver at Johns Hopkins Hospital, the prenatal monitoring of the pregnancy, so the ultrasound monitoring of the fetus and the monitoring of the mother, is done by the Center for Fetal Therapy. If parents choose to do fetal therapy, that is done by the fetal therapy team. And for those families, we will also do the delivery and be actually physically present there at the delivery. For parents that have a less severe diaphragmatic hernia, the prenatal care is done by one of our MFM colleagues, still delivering here at Johns Hopkins Hospital, and the care coordination is handled in exactly the same way. Yeah, the transfer of care, the transfer of obstetric care in anticipation of delivery happens when it is required by the care path. So for patients that undergo fetal, they transfer their care at 28 weeks. For parents that come from further away that do want a delivery here, we try to actually delay the transfer of care to as late as possible. So typically that's more like 34 to 35 weeks. So they have the option to be managed by their providers locally and remain with their families as long as possible. Our referring providers remain involved in the care of our CDH pregnancies because we try to also coordinate as much as we can between our providers where the visits for our patients can take place. So in order for that, we communicate with our providers so that they are in the loop. And obviously after delivery, we remain in contact to provide the outcomes, and families will return for ongoing postpartum care there. So we try to really have them involved as much as possible because it also helps the families. As a maternal fetal medicine provider that operates out of the Center for Fetal Therapy, I made several important observations. Because our pediatric care team and us have co-managed a wide range of diaphragmatic hernias over the last few years, we have really grown in our experience in holistic and really advanced care of these pregnancies. Our NICU colleagues are exceptional in providing a physiologic transition. So our ECMO rates have dropped from 50% to less than 10% for severe diaphragmatic hernias. And I think that is a really amazing achievement that I'm very proud of. And obviously our surgical team has also transitioned their repair techniques to a more physiologic muscle flap that actually allows the patch of the defect to grow with the individual and has a lower risk of reherniation and all that. So I think that although not being a pediatric provider, I have actually observed that we all learn from each other. And I think altogether, our care has become more individualized, but better for our parents. When the Center for Fetal Therapy opened at the Johns Hopkins Hospital, our pediatric surgical colleagues actually established a long-term multidisciplinary CDH clinic with the Kennedy Krieger Institute, which has really been invaluable in helping families to transition to the different care needs. Like, so as the babies grow out of their respiratory problems, more into their nutritional needs and the developmental assessments. So that has been a really, really great resource. And I know that many of our families continue to come to the follow-up clinic for years after treatment. At the Center for Fetal Therapy, we have 2 referral pathways. The one that's really important is for urgent referrals, where you have 24/7 access to one of our physicians, and that's the fetal therapy hotline, the 1-844-JH-FETAL. And that can be important in babies with diaphragmatic hernia, where you might be very close to the deadline when fetal therapy might be able to be offered. And I encourage you, anytime you have questions, it's always better to call 1-844-JH-FETAL.